Okay, so picture this. A patient presents with diarrhea. It's one of the most common things we see, right? But the list of what could be causing it is absolutely huge. So, as a clinical detective, where in the world do you even begin your investigation?
And that's the big question, isn't it? Figuring this out quickly, safely, and efficiently is what it's all about. It's not about memorizing a million causes, it's about having a system, a framework for your investigation.
So, here's our game plan. Think of this as our case briefing. First, we'll grab our detective's toolkit. Then, we'll profile the usual infectious suspects. After that, we'll tackle the tricky treatment dilemma. Zoom out to investigate an outbreak, and then open up the cold case file on chronic causes, like IBD. And we'll wrap it all up with a high-yield debrief for your exams. Right, first things first. Before you even think about ordering a single test, your most powerful diagnostic tools are the questions you ask. This framework is absolutely key to cracking the case right from the get-go. These 4 questions triage the whole situation instantly. 1. How sick are they really? Are we talking about life threats like sepsis or severe dehydration? Because that's the first priority. 2. How long has this been going on? Is it a sprint or a marathon? The causes of diarrhea that started yesterday are totally different from something that's been dragging on for months. 3. What does the crime scene look like? Is it watery? Is there blood? Is it fatty? Each pattern points to a different group of culprits. And 4, is this just one person, or could this be the first sign of something bigger, like an outbreak? You've always got to have that public health hat on. Okay, with those first questions answered, we've already narrowed the search. Now we can open the case file on the most common culprits, the acute infections. Let's think of these pathogens like different suspects, each with their own unique MO, their own way of causing trouble. The first huge clue is the type of diarrhea. So here's the analogy. Is it like a leaky faucet that's just been left on, pouring out huge volumes of water? Or is it more like a burglar has broken into the house, smashing windows and leaving a mess of blood and debris? The leaky faucet is watery diarrhea. This is usually caused by viruses or toxins just tricking the gut into dumping fluid. The burglar, on the other hand, is inflammatory diarrhea, also called dysentery, where invasive bacteria are literally damaging the wall of the gut. Now, for some of these culprits, the clock is your biggest clue. If symptoms hit just a few hours after a meal, it's not the bug itself growing inside you. No way. It's a pre-made stink bomb, a pre-formed toxin that was already lurking in the food. The classic examples are Staph aureus and the emetic type of Bacillus cereus, the one from reheated rice. They strike super fast within 1 to 6 hours. A little later, maybe 8 to 16 hours, you've got suspects like Clostridium perfringens in reheated meats. Now for the burglars, the invasive ones, their timeline is a bit slower. It might take a couple of days to develop. Suspect number 1 is Campylobacter. This is your classic undercooked chicken story, and you absolutely have to remember it's linked to Guillain-Barré syndrome. Next up is Shigella. Its calling card, it's incredibly contagious. It only takes a tiny number of organisms to make you sick, which is why it spreads like wildfire in places like daycare centers. And of course, Salmonella, from eggs and poultry, which is a really serious threat for the very young, the elderly, or anyone with a weakened immune system. Then we have a special kind of villain, Shiga toxin-producing E. coli, or STX. This one is different. It causes a really nasty, bloody diarrhea, but often without a high fever, which can throw you off. But the real danger, the thing you have to know, is that treating it the wrong way can trigger a catastrophic complication called hemolytic uremic syndrome, or HUS, which can lead to kidney failure. This is a massive do not miss. And that brings us to a really critical decision point. You've got a suspect in your sights. You think it's bacterial. So, do you reach for the antibiotics? The answer is a hard no. In fact, sometimes it is the absolute worst thing you can do. This is a classic exam trap, but more importantly, it's a vital real-world lesson. Okay, so you've got to know when to pull the trigger and when to hold back. You might consider antibiotics for severe traveler's diarrhea or for confirmed Shigella to stop the person from spreading it. But you must avoid them if you even suspect STEC. Why? Because the antibiotic stresses out the bacteria, causing it to release a massive flood of that Shiga toxin, which dramatically increases the risk of HUS. And of course, antibiotics do nothing for viruses. It's a perfect example of how the wrong treatment can be far worse than the disease itself. So far, we focused on one patient at a time. But sometimes the case isn't just one person, it's dozens. So our detective work has to scale up from the clinic to the whole community. We're launching an outbreak investigation. And the science behind this whole process is called epidemiology. To put it simply, it's about being a detective for an entire population. You're trying to figure out who is getting sick, where they're getting sick, when it's all happening, and most importantly, why, so you can put a stop to it. And luckily, there's a systematic playbook for this. First, you confirm you've actually got an outbreak. Then, you define exactly who counts as a case and go find them. You describe the data, time, place, person, to look for patterns. From there, you develop a hypothesis, like, I bet it was the potato salad at the company picnic. And then you test that idea. And finally, you act fast, control the spread, and tell everyone what you found. All right, let's switch gears. We're moving away from the acute sprint and opening up a completely different case file, the chronic marathon. When diarrhea lasts for weeks or months or even longer, we have to start thinking about inflammatory bowel disease, or IBD. This isn't an outside invader. This is the body's own immune system going rogue. So, the two main types of IBD are ulcerative colitis, or UC, and Crohn's disease. Here's how to think about them. Imagine UC is like a bad sunburn that's only on the very surface of the skin, and it's one continuous red patch. That's UC. It's superficial and continuous in the colon. Now, Crohn's disease, that's more like deep potholes in a road. They can pop up anywhere, from mouth to anus, with normal road in between. We call those skip lesions. And crucially, these potholes go all the way through the full thickness of the road. That's transmural inflammation. And this difference in pathology, superficial versus deep, directly predicts the kinds of problems we see. That superficial sunburn of UC explains a constant bloody diarrhea and the feeling of urgency. But the deep potholes of Crohn's, that transmural inflammation, that explains why it can cause these deep complications, like tunnels that form to other organs, called fistulas, or deep scarring that narrows the bowel, which we call strictures. The pathology explains everything. And here's a key point for your exams and for your patients. IBD is a systemic disease. The inflammation doesn't always stay neatly inside the gut. You have to look for clues elsewhere, in the joints, on the skin, and in the eyes. These extra intestinal manifestations are super common and can be a big clue. Okay, we have covered a ton of ground. Let's do a final debrief on this case. We're going to consolidate the most critical, must-know, non-negotiable clues for your exams and your clinical practice. Here is the absolute bottom line. 1, always start with your 4 key questions. 2, super rapid onset of symptoms means you're dealing with a preformed toxin. 3, never, and I mean never, give antibiotics if you suspect STEC because of that HUS risk. 4, link Campylobacter to Guillain-Barré. 5, know the difference. UC is superficial and continuous. Crohn's is transmural with skip lesions. 6, that transmural inflammation is why Crohn's causes fistulas. And 7, if you have a known IBD patient who's flaring, your first job is to make sure they don't have an infection on top of it. And just a quick reminder, this content is for educational purposes only and does not constitute medical advice. Please always consult a healthcare professional for any personal medical concerns you might have. So there you have it. We've cracked the case of diarrhea by applying a systematic detectives framework. But here's a final thought to leave you with. What about its opposite? How would you take these exact same principles, how sick, how long, what's the pattern, and apply them to investigate a patient who comes in with constipation? The detective's tools are exactly the same, only the clues have changed.